Well, thank you to give me the opportunity to talk about this important clinical question, I would say. So I'm going to briefly talk about thrombosis and bleeding. So first about incidence of thrombosis. I will briefly go into what's new in our understanding of the pathogenesis of thrombosis. And then two important questions, which are how to treat MPN-associated thrombosis and the question of DOACs versus vitamin K antagonist, and then how to prevent MPN-associated thrombosis. And then I will have a few slides about bleeding and bleeding risk. So I would go here again very quickly into that, but as you are all aware of, thrombosis is the most important complication in MPN, with about 20% of newly diagnosed MPN patients having thrombosis in recent meta-analysis, including over 13,000 patients, and with a well-known predominancy of arterial thrombosis over venous thrombosis. This quite recent paper also analyzed the hazard ratio of thrombosis during the follow-up. And so in yellow, you only see the data of the most recent patients. And you see that thrombosis also happens during the follow-up with a 1.6 or a hazard ratio in arterial thrombosis, and over 3, the hazard ratio of 3 in venous thrombosis. So that's an important clinical issue in these patients. So why thrombosis happens, and here again I will go very quickly. We recently wrote a review on trying to give all the evidences that are available on the different cell types that are involved in this thrombosis, so including platelets, red blood cells, neutrophils, monocytes, and endothelial cells. And today I will just talk very briefly about the interaction between platelets and neutrophils. Neutrophils are known to promote thrombosis because they can release the content of their DNA, which is called neutrophil extracellular traps, which is a mechanism that has become quite important in the field of thrombosis in general, not only in MPN. It has especially been described during the COVID-19 disease. But so during MPN, netosis is important, and the thing is that netosis is driven also a lot by platelets. So platelets are not only involved in thrombosis by themselves, but only in the fact that they can directly promote netosis from JAK2-VF neutrophils. That was observed in mouse models with mice having the JAK2 mutation in their blood cells. The mice treated with aspirin have less net markers and are doing more thrombosis, and even patients who are under aspirin treatment, despite having the same number of neutrophils as patients without aspirin, the patients under aspirin have less net markers. This gives a new look, I think, on the position of aspirin in the anti-thrombotic treatment in these patients, as they seem to have a double role in thrombotic complication prevention or even treatment. What is also new in this pathogenesis of thrombosis, the red blood cells are also cells that are involved in thrombosis, not only by the fact that there is a high number of red blood cells, but also because red blood cells are able to release microvesicles that can promote arterial vasospasms. That was described in 2020. And also the facts and all this literature about the JAK2-VF mutation in blood cells increasing atherosclerosis with different types of studies on that. would suggest that to have an MPN would increase the risk of having atherosclerosis and subsequent arterial thrombosis. This has been nicely shown in mice, but not really, there is no clear evidence in patients about that. So these were a few slides about what's new in our understanding of thrombotic pathogenesis in MPN. Then the question I was trying to answer is how should we treat this MPN-associated thrombosis, and what are the current evidences about whether or not we can use DOAC in these patients? This is a review which has been published in 2021, so a systematic review of antithrombotic treatment of patients who have an MPN and also who have had a venous thromboembolism, so a VTE. And so this meta-analysis, this review, included a lot of studies, and with a very serious look at all these studies. They only 10 studies could be included in this big review, 1 prospective study, 8 retrospective, and 1 case series. And so this included 738 patients who had a history of MPN and a history of VT. And what they could conclude is that when they looked at the percentage of recurrent VTE, well, recurrent events after VTE, was 17.6% of patients who had a recurrent event when they were under VKA and cytoreduction, and the patients treated with DOAC and cytoreduction had 7.9 recurrent event, and patients who were treated with VKA, antiplatelet, and cytoreduction for a strange reason had more recurrent event than this group of patients. Anyway, this is not a prospective comparative clinical trial, but this suggests that DOACs are as efficient, at least as VKA, in preventing recurrent thrombosis in patients with MPN and VTE. So this provides the background to perhaps for a trial that would directly compare VKA and DOAC in patients with MPN and previous VTE. Here also I showed the analysis of Professor Barbui in 2021, who reported 442 patients who were treated with DOAC and in the context of MPN, but these were not only patients with thrombotic event, they were only patients with atrial fibrillation. And so when we only look at patients who had a venous thromboembolism, so 239 patients, the incidence rate was, well, the thrombosis after DOAC start was 9.2% of patients, and the bleeding, the percentage of patients with bleeding was 5%. So yes, this study suggests that DOACs could be used in these patients, even if it has not really formally been tested, and no clinical trial has been done. And so I think this is one of the unmet clinical needs that has been summarized in this MPN Hub. And I think really we should consider to have prospective studies that evaluate the anti-thrombotic strategies in patients with MPN-related VTE. I don't know what you think about that, but maybe we could talk about that later. The thing is that, so that's about treatment, but it would be nice to better assess the thrombotic risk in these patients. So how can we assess the thrombotic risk? So specifically to assess the thrombotic risk, there's this IPSET thrombosis score, which has been developed for ET, and new scores are being developed. There's the the group of Jean-Jacques has developed this score to assess the arterial risk and venous risk. And in this arterial risk score, they included the cardiovascular risk factor, TET2 and DNMT3A mutations, the age, which is already included now, and a prior arterial thrombosis. And they could show that using this score, they could discriminate quite well patients with high risk and low risk. So the development of new score is something that would be useful to better assess the thrombotic risk. Another way would be to find biomarkers, and biomarkers are even better when they are really linked with the pathogenesis of thrombosis. And so I talked about the importance of netosis, NET biomarkers. We could observe that one of these NET biomarkers, which is DNA coupled with myeloperoxidase, was lower in patients without thrombosis than in patients with thrombosis, suggesting that this could be a useful biomarker to predict thrombosis occurrence. So we now have a clinical study ongoing in France with 394 patients who have been included, for whom we will quantify plasma NET biomarkers and see whether or not they correlate with the thrombotic risk and history of thrombosis, but having a prospective trial to really quantify biomarkers and correlate them with the real prospective occurrence of thrombosis would be also a very useful trial to perform. There are also the option of having new anti-thrombotic strategies. So DOACs at reduced dose is something that could also be really interesting to give to patients. Now, most of the patients receive aspirin, and the question is whether DOAC at reduced dose, which are not really associating with any bleeding risk, whether this could do better than aspirin. And so there are some clinical trials that are now ongoing that are investigating this question. A few slides now about the bleeding risk. The bleeding risk is not as important as the thrombotic risk in MPN, but still about 6.2% of patients, of newly diagnosed MPN patients, have bleeding complication, and this is especially true in myelofibrosis, where the bleeding risk is almost as important as the thrombotic one. And it's mostly mucocutaneous bleeding, suggesting involvement of platelets and von Willebrand factor. Here are summarized the main risk factors for MPN-associated bleeding, which is advanced age, disease duration. So yes, the MPN subtype with myelofibrosis having more bleeding than ET and PV. Splenomegaly, which perhaps suggests that it's myelofibrosis. And thrombocytosis, which is a well-known bleeding risk factor because it is associated with acquired von Willebrand syndrome. Indeed, the bleeding risk has been, the pathogenesis of the bleeding risk has been mainly said to be due to two actors, the von Willebrand factor and platelets. Perhaps I should start with platelets, which are well known more than von Willebrand factor in the bleeding. Well, whether or not there is a platelet dysfunction in MPN is not so easy to assess, because the platelets in these patients, when you study the platelet function in these patients, most of the time the platelets you study, because they have been taken out of the patients, they can sometimes be activated during the blood sampling, and so the platelets that are studied are platelets that have already been activated in the tubes, and so it's only remnants that we study. And so the platelet dysfunction we observe, it is hard to know whether it's a true in vivo platelet dysfunction. So here is summarized the platelet function, which is platelet maximal aggregation in response to different agonists in healthy controls in gray, in patients with calreticulin mutation in blue, and in patients with JAK2 mutation in red. And depending on the agonists, there is indeed platelet dysfunction in patients with MPN without any clear difference between calreticulin mutation or JAK2 mutation. There's also a decrease in both of these patients in the platelet dense bodies content, suggesting that the platelet blast study have already released the content of their granules. And why do we say that? It's because when you measure in blood the platelet activation markers with ELISA, you see that platelet activation markers such as CD40 ligand and P-selectin are increased, suggesting that really in vivo platelets are activated, but in vitro platelets seem to be hypo-activated because they actually have already released the content of their granules. Or so whether or not there is a platelet dysfunction is hard to assess. And the other parameter that is well known to be related with the bleeding risk is acquired von Willebrand disease. Actually, platelets, in order to adhere to the vessel or the subendothelium, they need von Willebrand factor, and von Willebrand factor is a big protein that is released by endothelial cells, and the bigger the von Willebrand factor is, it's a multimeric protein, the more effective it is. The thing is that in MPN, the platelets are hyperactivated and they bind high molecular weight von Willebrand factor. So they keep it with them. And so when there is an injury, this high molecular weight von Willebrand factor are not available anymore to play their role in primary hemostasis. So this acquired von Willebrand disease or von Willebrand syndrome is known to be associated with the number of platelets, because the more platelets you have, the more high molecular weight von Willebrand factor are released. So there is this well-known association with a very high platelet number and bleeding risk, but the question also is whether or not with the not so high platelet number, you can also have this acquired von Willebrand disease. So in order to know whether or not there is a risk for acquired von Willebrand disease, we can measure this von Willebrand factor activity and measure the amount of factor A, which is linked with the von Willebrand factor. And the problem with that is there are different techniques to measure von Willebrand factor activity, and depending on the techniques that I use, the results are not always the same. So some techniques seem to be more sensitive than others to this high molecular weight von Willebrand factor. So here again, I think there is some work that could be performed to better assess the bleeding risk, especially with investigations on this von Willebrand factor activity and using different techniques, because it seems like, yes, some could be more efficient than others. And so in summary of how to assess the bleeding risk, I think that take advice from a hematologist who knows bleeding disorders and hemostasis disorders could be really useful in clinical practice. So I think this is my last slide. In summary, I think it is still difficult to assess the thrombotic risk for individual patients, and thrombotic scores or biomarkers are still really useful to be found. Use of DOAC still needs to be evaluated in clinical trial, and this is especially true for patients with thrombosis in unusual sites, such as cerebral vein thrombosis or splenic thrombosis. And about the bleeding risk, because bleeding complications are not as frequent as thrombotic ones, There is currently no score and a few biological tests to test the bleeding rates. So here again, I think there should be some efforts on that. So I'm happy to hear your thoughts about all that.
Very good. Thank you. Thank you, Claude. May I say something?
Sure.
Do you think that the presentation of the rate of thrombosis today should be modified? I think the rate of thrombosis we have today is different from the rates reported in the old series of patients. Not only the rate of thrombosis, but also the types of thrombosis. Usually we know that rate of arterial events is the double of that of venous events. But today, do you think we are at the same rates in contemporary patients with PV, ET, as well as myelofibrosis? Because many things have changed over time now. We do initial, very early diagnosis of these diseases so that we treat earlier today this disease, so that the rate of incident thrombosis can change. So we should think about the rate of thrombosis for clinical trials done today, because it's my impression that in several series of patients, the reported thrombosis today is less than the previous one. This is the first point. The second point, do you think that we should continue to look at risk factors at diagnosis and not to the risk factors occurring during the follow-up? Because during the follow-up, having a thrombosis could be a risk for other events in these diseases, because the same mechanisms of thrombosis can be also involved in other outcomes in MPN, for instance, cancer. So that if you consider a thrombosis occurring during the follow-up, this could be a risk factor for other events with the same, maybe sometimes pathogenesis.
No, I completely agree with both of your remarks. I think that it is true that now in 2023 and even 5 years ago, the incidence of thrombosis is probably not as high as it was 20 years ago, but still, there are still some patients who we see and who have recurrent thrombosis despite having a proper cytoreduction, which is properly efficient. And so I think there are still some clinical situations where we don't understand why thrombosis recurrence happens, especially, in my opinion, in the case of thrombosis in unusual sites. So yes, that is to answer the questions about recurrence. The questions of incidence of thrombosis at time of diagnosis remains the same, because as long as the disease is not diagnosed, of course, we cannot do much better than it was. Your question about the risk factors during the follow-up rather than at the time of diagnosis, of course, the risk factor, the thrombotic risk factor, arterial and venous one, should better be controlled during the follow-up. But as we know, it's not always. Some can appear, some can disappear.
No, but I wasn't telling you about the risk factor for thrombosis. Thrombosis itself is a risk factor for other events that are not related to recurrence of thrombosis. For instance, for cancer, for instance, for evolution of the disease.
That thrombosis could be a marker of disease evolution, you mean, or
exactly.
It is a well-known marker of solid cancer. That
exactly.
kind of a solid cancer. Yeah. Yes, which means that a patient with MPN having a thrombosis during the follow-up should make the hematologist that he or she still has to look for a solid cancer that could be something completely different from the MPN. That's what you mean.
Exactly. We published this in Blood 2 years ago, a series of patients, a case control study. And we have seen that those developing arterial thrombosis were much more at risk of developing solid tumors. For instance, carcinoma, not dermatological tumors, but very strong tumors such as carcinoma. So we have to see thrombosis in another way today as compared to the previous reports, you know. Yeah. So we have the risk factor for thrombosis, but thrombosis itself, when it does happen, is a risk factor for other events. So this is a new area of research in these diseases, I think, for many reasons, for biomarkers of inflammation, for the persistence of some mutation that are bad mutation, as you presented, TAT2, for instance, for arterial and not venous thrombosis.
Yes, and also there's still, I think, a lot of question about the treatment, DOAC, VKA, aspirin.
Exactly.
So
yes. Of course, this is corrected for the treatment, of course.
And there are still many unanswered questions about treatment strategies in these patients. Often clinicians wonder whether they should add DOAC and aspirin or only put the patient under DOAC only. So I think there are still a lot of unanswered questions.
Yes. So I think this is a new way to see the same things.